Good morning and welcome to Southern Maine Healthcare's Medically Speaking. I'm your host, Robert Erickson, and for the next 30 minutes, you'll hear about medical issues and topics of the day directly from leading medical professionals at Southern Maine Healthcare. Welcome to this week's Medically Speaking. Our guests today are Dr. Don Burgess, a pediatrician with SMHC Pediatrics who is board certified in developmental behavioral pediatrics and director of the Center for Developmental Pediatrics, and Susan Risigo, who is a nurse care manager at the center. Welcome to the show.
Thank you.
Thank you.
Let's start with an overview of the center, and then we'll get into specifics about the program and its services and your roles in it. Dr. Burgess, let's start with you. How did this all come about?
Around about 2003, there was a group of us that got together and did a needs assessment of our service area, which is most of York County, and decided that evaluation and management of developmental disabilities was a big need in the area. So we put together a grant proposal and got funded and started what later became known as the York County Learning and Behavior Assessment Clinic. And what we did is we had different disciplines, myself as a developmental pediatrician, two neuropsychologists, a speech therapist, and an occupational therapist. And we did multidisciplinary evaluations of kids. And then I subsequently did their medication management and some of the management of helping them get through the school system and through the case management system and things like that. That outside clinic kind of folded around 2008, 2009, and we kind of folded it into Southern Maine, then what was Southern Maine Medical Center, now Southern Maine Healthcare. And we've been kind of slowly building the program back up again. We still work with some neuropsychologists, speech and language clinicians, and occupational therapists to do multidisciplinary evaluations. And then we do follow the kids afterwards, sometimes doing medication management, sometimes helping them navigate the mental health system or the school system. But that's basically what we're doing now, is trying to build ourselves back up to a fully functional multidisciplinary clinic.
So is this a need that has cropped up in recent years here in York County? I mean, why here in York County?
When we first did the needs assessment, we found that people needed to travel pretty big distances, and considering the population in here and how close we are to some bigger centers and things, people either had to go to Portland or way down to Portsmouth or even Boston for this kind of care. So we really felt like this was something that could be provided locally. Doesn't require a lot of logistics as far as hospital or lab or anything like that. It's a specialty that kind of does its own thing. It doesn't require needing to do imaging and things like that. And we really just felt like people shouldn't have to travel for that service.
So is it a physical space or is it a group of practitioners and providers?
Right now, it's a physical space, but what our hope is, with some shifting around and whatnot, is to get everybody under the same roof. So having the neuropsychologists, the speech therapists, occupational therapists, and physical therapists under the same roof is really our goal, and that's been our dream for a long time, to have it all in one location.
And Susan, what's your role as a nurse case manager?
I provide support to the patients and their families by providing education, helping them identify resources in the community to make sure that the needs are met. I work with Dr. Burgess when we initially evaluate kids to identify needs at that time and move forward throughout our relationship, which can oftentimes span a decade or more. So I become very familiar with the families, and they also in turn with myself, and we achieve a level of comfort which is really beneficial because we work closely in making sure medications are being administered correctly, that we make adjustments as appropriate, that kids are getting the right services in the community and in their schools. So my role is essentially to support families and kids as we care for them.
So what sort of cases are you seeing at the center? What would you say are the most common issues that you deal with?
We oftentimes care for kids with developmental disabilities, including autism spectrum disorder, kids with ADHD, Tourette's, depression and anxiety. We care for kids who have fetal alcohol effects, neonatal abstinence syndrome. Kids with developmental delays might also include kids who have speech and language, cognitive delays, occupational fine or gross motor delays. Very pretty wide spectrum of disorders.
So if you're a parent who suspects your child may have an issue, how do they start to think that this might be an appropriate place to get care?
Well, we have a process that people call or get a referral from their primary care physician, and then Sue Risigo does the initial intake interview, which gives us most of the information, and then we go out and get records and old evaluations and school records and things like that to kind of put the evaluation together. And then they meet with me for about an hour and a half. I go over all the records and also talk about what the more pressing issues are, because some of these problems aren't just as simple as I have ADHD or I'm having trouble focusing. It's I'm having trouble focusing. I'm in trouble in school. I'm not attending school, which we see very frequently because of either anxiety or behavior issues within the classroom. We try to figure out what the major issues are and then start to tackle them one by one.
So what are the age groups? What kind of age groups are we talking about here?
I would say that we see from 0 or even 1 week or 2 weeks of life to about the age of 21. So we follow kids right through college. And then we usually try to transition over to adult services after that. Although it's important to note that there isn't the equivalent of what I do as a developmental behavioral pediatrician in the adult world. So it really falls on the primary care providers and mostly psychiatry to kind of take care of those folks if they have needs medication-wise or care coordination or anything like that. So we're really unique in the fact that pediatrics has this subspecialty.
So as a pediatrician, walk us through a little bit about how you might deal with a newborn and how you would determine if any of these issues are present. Are there cues that you look for right away?
A lot of times you do. I mean, even in regular well child care, there's certain milestones we're looking for children to meet, including infants. And what happens is when you're not meeting those milestones or they're very delayed, that's when we start to sort out what's going on. So the first things you usually notice are motor skills, whether they're lifting their head, whether they're able to pick their head up when they're on their stomach, all kinds of things around how much eye contact are they making or do they have a social smile. Those are all really important developmental milestones that just about every doc who takes care of infants knows what those milestones are, and we have references and things like that. So I think it's really, are you hitting those milestones? And if not, why are you not hitting those milestones? And so that's where the evaluation goes, is it's a lot of observation, it's a lot of some direct testing of certain milestones that we want babies to meet. And then if there's delays, you start investigating what's going on.
So when did awareness of these various issues occur? Is it something from the last 20 years, or has it been something that this has been going on for generations and we're just becoming more aware of them now?
I think these are things that have been around for generations. They've had different names. So a lot of times kids who were just called behavior problems now would meet criteria for being on the autism spectrum. The other thing we've seen is a lot of kids get diagnosed with Tourette's now that have mild Tourette's, but they were called something different years ago. And now people are following the criteria for Tourette's. And Tourette's has its own unique kinds of behavior and learning issues that go with it. I think we're better at picking up developmental delays. We've, over the last 15 years or so, we've had pediatricians doing developmental screening in their office using a tool to kind of determine if you're meeting all those milestones rather than just kind of looking at a baby. So we're a lot more scientific about screening for developmental disabilities. And every few years, the criteria change. So recently, about 3-4 years ago, the criteria for autism spectrum disorders changed dramatically, and there was some renaming of some of the disorders that go along with it and things like that. So I think we've gotten better at diagnosing. It isn't that these things are necessarily increasing. We do know that autism is both increasing and being identified more frequently.
Susan, you're nodding your head. Looks like that might be something that you agree with.
I absolutely agree. I think we're doing a better job at identifying kids who have delays earlier. And that's critical because the sooner we identify kids, the sooner we can intervene. And the sooner we intervene, the better the outcomes, the better quality of life for the child in the long run, and the better for the community. So I believe that the work we do is vital, and the work that primary care providers do in screening kids with needs is essential.
Now, as a nurse case manager, you deal with the parents. How does that work? Are there things you have to do to help the parents deal with all of these issues?
Well, the intake interview is essential because it allows for us to establish a relationship with the parents and create an environment of trust. I do a lot of education, but it only can occur when a patient or a parent is comfortable. So there's a lot of reassurance. We talk a lot about particulars with regard to what is actually going on and break it down so that we can identify what really is the issue. That initial intake interview is very comprehensive, and it allows us really to gather information that's essential to decide how we're going to go forward. And we, from that first moment, begin to devise a plan for how we're going to help, how we're going to get the kids identified, figuring out what their diagnoses are, and really how we're going to provide not only the child, but the family with the support they need. So it's a lot of reassuring.
So how essential is the acceptance of the parents in this whole process?
It is essential because really the child's first and primary advocate are their parents. And a child who has a parent that has resources, whether they're cognitive, emotional, financial, social resources to provide adequate support, is a child that's going to be better situated to have better outcomes.
And I'm assuming these issues run across all socioeconomic levels.
Absolutely.
What would you say to parents listening to this who suspect that their child hasn't been evaluated, but there might be some issues at school? What would be the first step that they should consider?
I would encourage them to speak first to their primary care provider, their pediatrician or family practice provider, about what their concerns are. And then from there, discuss with their provider the possibility of having them come on and give the Center for Developmental Medicine a call.
Dr. Burgess, if they don't have a provider, what would be the first steps that they would take at that point?
Well, I think if a lot of the issues are present in school, they should always start with school to see what's going on there. Perhaps school's willing to do some testing or look into it a little sooner. So that's always a resource that they have to use. The other thing is they can call the center directly, and we may need to find somebody to be able to do a referral to us, but we can take people on that don't have a primary care physician as well. But I think you want to look at all the different environments the child is in and see what would be appropriate for starting the evaluation process.
So of all the conditions we talked about, what are the most challenging to diagnose, and are there some that don't appear until 5, 6, 7 years old that you wouldn't maybe see in an infant?
I do think that autism spectrum disorders still are somewhat difficult, although we have some really newer tools that we can use to make that diagnosis. It used to be that the average age of some kids getting diagnosed when they've had it since birth is around 3, and then for high-functioning kids on the autism spectrum, those kids weren't diagnosed until they were 8 or 9. So I think now we've done a much better job being able to pull that age back to around 2. Part of the problem with it is the early first year and second year of life, there's really there's a few warning signs like poor eye contact or absence of a social smile or things like that you can look for, but there's very little sometimes that you see in the very beginning, and then all of a sudden they're not talking, or they were talking and they have what we call a regression in developmental milestones. So a regression in anybody where they develop a skill and then they lose it is that's a red flag that says there's something going on. So I think we're doing a much better job. We'd like to get that age down, that average age of diagnosis down to 2, and we do that diagnosis at 2 now with the tools that we have.
Now, you mentioned lack of a social smile. What is that?
So a social smile is when you make eye contact with your baby and they immediately smile. And that's just, they're doing it because they see somebody familiar. There's no prompting that's needed for it. There's no exchange necessarily, just the eye contact. And I think that's something that some of the infants that later are diagnosed with autism spectrum disorder, they lack that, and some people may miss that. Sometimes with the encounter in a pediatrician's office that can only last sometimes 15 to 20 minutes, you may not see that, or you may find that there's a little bit of a smile, but you're not sure if it's a social smile or not. But I think it's an immediate kind of reaction to seeing somebody's face.
You're listening to Medically Speaking, and we're speaking with Dr. Don Burgess, who's the director of the Center for Developmental Pediatrics, and Sue Risigo, who is a nurse care manager at the center. We'll be right back with more of our discussion right after this.
For high-quality walk-in care, the best team is always on the ball. Look for Southern Maine Healthcare's Orange Walk-in Care Ball. With convenient locations open every day, it's your guarantee of quality walk-in care delivered by your hometown team.
So you mentioned a lot of different conditions. Maybe you could define a couple of them that people might not be familiar with. Are there a couple that you see on a regular basis that maybe you could talk about?
I think as a group, we're starting to see, because genetic testing is so sophisticated now, we're starting to see a lot of genetic syndromes. And there's just a huge group of them, and they all have different features. Some do share features with each other, either cognitive or intellectual deficits, or the autism spectrum disorder and learning disabilities. But that as a category is something that we're seeing more and more, where they may not necessarily be on the spectrum, but they have a lot of learning issues and a lot of developmental delays or issues with learning in school. So I think that group is something that has been increasing along with the kids with autism spectrum disorder. Tourette's is certainly something that's been around since years and years and years ago, when the first person described the set of features that go along with Tourette's. I think we're more sophisticated at diagnosing it. I think we know what's associated with it now. It tends to have some ADHD with it. It tends to have anxiety and obsessive compulsive behaviors. And then, so when we diagnose somebody with that by using the criteria we have, we're able to kind of predict what's going to happen. We know what we have to do interventions for and things like that.
Now, a lot of children have bedwetting issues. At what point in their development does that become abnormal?
Well, every child, when they're babies, bedwets and has incontinence. And what happens over time, closer to the age of 2, is that children are able to physically control their bowel and bladder. And then sometimes the one thing that's left over is bedwetting at night. So in toddlers, a lot of times it's a normal kind of progression. It's more of a sleep issue where the child is sleeping way too soundly and not getting the signals to wake up and kind of tighten up the sphincter that holds the urine in the bladder, or doesn't wake up and go to the bathroom. It starts to become more of a problem when kids are more aware of it, and it's a problem with things like sleepovers and things like that. At 5, there's about 30% of kids that still normally wet the bed at night. So we don't call it a big issue as far as is there anything medically going on. We do work it up if kids get into their teen years and still have bedwetting, but it's very seldom that we find anything. I mean, every once in a while we'll find an anatomic or something going on, but usually those kids have incontinence during the day as well, so that's the signal. So I think, we try to kind of make it a normal developmental variation that some kids have and try not to make a big deal out of it. We do use medication sometimes in older kids to be able to control it a little bit until their sleep cycles mature enough to take care of the problem. And usually by adolescence or right around puberty, a lot of kids will stop bedwetting. There's a very small number of kids, probably less than 1%, that actually bedwet into their teen years. And those are the kids that we look into, whether there's other reasons for it. The biggest reason for somebody to totally be dry at night for several years and then start to bedwet is stress. So a lot of times if we see that pattern, we start looking for anxiety or stress or bullying at school or something going on in the family that may have set it off. So it can be emotionally triggered as well.
I want to talk a little bit about anxiety and depression. The school years obviously are intimidating for a lot of children. When does anxiety and depression become an issue or an abnormality?
I think that anxiety and depression are when it affects a child's sense of well-being, their ability to function in their lives, in school and in the home environment. It's also important to remember that many of these syndromes do not exist in solitary. For example, a child with ADHD is more likely to be a child with anxiety. So a child with autism is more likely to have issues with ADHD or anxiety. So it's oftentimes not just one single syndrome, but a mix of syndromes, a mix of diagnoses that we're dealing with. So again, that's something that oftentimes when you treat, you have to kind of tease out what's at the forefront, what's affecting the child's sense of well-being and their ability to be most successful. And we try to address that first and then move on to the next.
The other thing that I think is important to note, and what's been on the news, is the fact that chronic stress, chronic anxiety, past traumatic experiences, we're starting to recognize that those cause a lot of physical symptoms and actually physical almost damage that you can have from having chronic stress. So we're dealing with a lot of families that have stress that's been multi-generational stress, and looking at whether they've had these things called adverse childhood experiences, and then trying to kind of break that cycle of chronic stress so that the children growing up now can have the potential for being much more resilient to stress in general. But, for instance, we're seeing a lot of gastrointestinal issues related to anxiety. So we work up a lot of abdominal pain, diarrhea, vomiting, those kind of things. A lot of times they turn out to be stress related. So they're physical symptoms that actually come from stress, because all of these things are neurologically based. So your brain kind of runs all the different systems of your body, and when it's chronically stressed, it may set off different kinds of symptoms. So the first symptom we may get when somebody comes in to like a general pediatrician's office is abdominal pain or chronic diarrhea or something like that. We have to medically look at it to make sure there's nothing going on, but many times we don't find anything medical going on, and it's related to, again, something like bullying in school or something going on in the family that's causing chronic stress.
So if a child is diagnosed early on, how would your care progress through the child's life?
For example, if we're starting with a child who's about 2 years of age, we would do, of course, that initial evaluation. And then from there, we'd start to look at trying to identify services in the community. We work closely with Child Development Services, which is under the Department of Education, trying to get a child hooked up with services. Initially, up until they're age 3, they get in-home support, in-home treatment, direct treatment in the home. And once they hit 3 years of age, we start to see kids may enter into a specially designed preschool program for kids with developmental delays, where they'll start receiving occupational therapy, speech therapy, and if needed, less often physical therapy, straight up until they enter kindergarten, when they'll enter into the school system directly, and through the individual education programs and 504 through planning, special education programming, they'll receive services including, again, OT, PT, speech, maybe special education supports, counseling in the school setting. Kid may start on medication if it's appropriate, at any time. Sometimes we start younger. Oftentimes we start in school so that the kids have the ability to self-regulate and actually have access to being ready or able to be educated. And from there, we may, as the children progress through elementary school, those needs may evolve and change, and we work with the families and the schools and the providers to make sure their needs are met. We often find once the kids hit middle school and adolescence, their peers are socially taking off. There's a rapid change, which for our kids with developmental delays, autism, that can be a time of particular stress because they don't have the capacity to keep up with the maturity and the changing social environment in the school environment. So they might need the supports of a social skills group or speech and language services that directly address those kind of social needs, as well as counseling services. We support them through high school, and from then, some of our kids go on to college, and testing can support additional supports in the college through the disability offices within any particular college. Testing and diagnosis may support them in their academics by providing them with supports within the college setting, scribes, tutoring, additional test-taking time, and all throughout that span, if it's necessary, working with parents and kids about appropriate medication.
Now, we've mentioned schools several times in this discussion. How important is it that the schools are supportive in all of these issues?
It's incredibly important because as you enter kindergarten, you're in that environment until you're 17, 18. So it's really a huge part of the child's life where a lot of different developmental issues can pop up, as well as there's a lot of things that the way kids mature that are influenced by how well they're connected with school.
So we have limited time left, but I wanted you to talk a little bit about the Executive Functioning Coaching Program. That's another facet of the center, and maybe you could describe what that is.
Executive functions are the ability for someone to start to be independent, taking care of themselves and doing things like schoolwork and homework. It has to do with prioritizing and time management and organizing. And it's a skill that we kind of expect our kids to learn when they're in middle school. And a lot of kids have difficulty with that, especially kids with ADHD, definitely kids on the autism spectrum, kids with Tourette's, other learning disabilities. And so several years ago, there's a group down in Portsmouth, New Hampshire, that has developed a series of books on how to teach kids executive functions. And so we now offer that as a service as part of the center. Shannon Cotter is a master's level psychologist who has taken that program and put it together to be a tutoring service that we provide. And then she provides support for a month or two afterwards to kind of hold the kids accountable for what they need to be doing, really looking at and tweaking the plan that she develops with them to be able to take care of getting all the work done that they need to be successful in school.
So if someone hears this program and they think, I'd really like to get my child into this program, what is the best way for them to reach you?
The best thing, again, is to go through your primary care provider. They would know how to get in touch with us and how to do a referral so that we can start the process. If you want to refer directly, we may still need to get a referral from your primary care provider, but you can call the center at 207-467-8930, and you'll talk with one of our clinic coordinators, Denise, who will put everything together and then start by making an appointment for a phone intake.
Well, Susan and Dr. Burgess, thanks for coming down to the show, and it's been great talking with you here on Medically Speaking.
Thank you very much.
Thank you.
Join me next week at this time for a new guest and an enlightening discussion about healthcare in our communities. Brought to you exclusively by Southern Maine Healthcare, your trusted resource for healthcare in Southern Maine.